Welcome everybody to this Saturday morning webinar where we're going to be discussing DBS. Many of you know me and I love to see my patients participate in these things. For those that don't, my name is Dr. Jill Farmer and I am the Director of Movement Disorders at Global Neurosciences Institute. And my partner is Dr. Adam Sarkar, and today we'll be discussing DBS from the surgical perspective, and then in the Q&A we'll get to some of the questions about who's a good candidate and when a Parkinson's patient is seeing a movement disorder specialist, how do we know when to refer and how to refer and things like that. But I wanted you to have the opportunity to meet Dr. Sarkar, and without further ado, let me introduce him. Dr. Sarkar is a nationally recognized Westinghouse Scholar. He attended Brown University as an undergraduate and has participated in research all over the world through the Ludwig Institute in Switzerland, the Rockefeller University in New York, University of Georgia. He received his MD PhD from the University of Miami School of Medicine, where he conducted the Department of Physiology and Biophysics with a focus on molecular neuroscience. His fellowship at Columbia University in single molecule mechanics, nanotechnology, and instrument design were the focus of his postdoctoral work, and his postdoctoral fellowship was performed amidst a neurosurgical residency at the Mayo Clinic in Rochester, Minnesota. His first faculty appointment was at the Ohio State University Department of Neurological Surgery as an assistant professor and director of neurological nanomedicine, ultimately heading the epilepsy, tumor, and stereotactic programs at Ohio State University, and was the co-director of the functional neurosurgery program there as well. Dr. Sarkar joined Global Neurosciences Institute in January of 2019 as a neurosurgeon and is a professor in the Department of Neurosurgery at Drexel University College of Medicine. Dr. Sarkar serves as the director of the Stereotactic, Functional, and Epilepsy Surgery program for Global Neurosciences Institute. And we are thrilled to have with him, and it's been a pleasure working with him. So without further ado, talk to us about DBS.
All right, Jill, wow. Now that you say all that, that makes me feel tired.
I was tired reading it.
So I'm going to get started, and I know it's a very, in a way, unusual format, but as Dr. Farmer said, these are unusual times, but we're not going to let the time hold us back. I think with everything that Jill mentioned, I don't have to reiterate, but I'm delighted to be part of Global Neuroscience, and I'm absolutely excited to be here in Philadelphia. And I think that it's a very important thing for all of Jill's patients to understand that at GNI, or Global Neuroscience, we're really a consortium of neuroscience specialists. So we've got neurosurgeons that can help you in just about any realm of neurosurgery, from pediatrics to adults, from tumor to vascular, and in particular for this population, for what we call functional or movement disorders. Equally, as you're all well aware, Dr. Farmer is an integral component of our neurology practice. And so in addition to neurosurgeons in Global Neuroscience, we have neurologists. And not only do we have neurologists, we also have for the movement disorder population, which is very important, neuropsychology, because something that's very unique about the functional patients and functional programs is that you really rely on a whole host of people to get you through your health care. And the great advantage that Global Neuroscience has is that you're not seeing somebody in multiple different settings, maybe at multiple different institutions, but we're one big tent and we can streamline your care because we're one institution. We also have specialists, if you are ever to need it, that are neuropharmacists, for instance, and even we have a neurological emergency department. So again, we're here for your emergencies and for your elective things, as well as helping you with your medications. And then finally, I think it's important for everybody to know, if you don't know this, that at GNI, we span a very large footprint from all the way to southeastern Philadelphia or Pennsylvania even, where ultimately we'll have a wonderful new clinic called the Philadelphia Neurological Institute. We go all the way up to New Jersey and Robert Wood Johnson in Hamilton. and we're even as far out west as Suburban Community Medical Center. So that's just a little bit about Global Neuroscience in case any of you weren't aware of that. This slide just shows that not only do I spend time in the OR, but that was where I did my MD and my PhD. New York City, which is a place I love, is where I did my postdoctoral fellowship, and that was outside of our apartment. I've got kids that keep me busy. They grow up, and then I don't have to take as much care of them, and then I can do some of the things I like to do, which is getting outdoors. Now I think I really want to focus on the neuroscience aspects of movement disorders. And I can say that neurosurgery is one of those really special fields where we're privileged to have been a part of human medicine for almost as long as there were human communities. And we know that there was neurosurgery that was being done of a sorts almost 7,000 years ago. And that's pretty incredible. And so we inherit this long legacy of expertise. Back then it was probably more trial and error, but now it's refined into expertise. We also understand that the currency of the brain is electricity. It's almost an unusual thing to imagine, but much like your cell phone works on electricity, your cable works on electricity, your brain works on electricity. And the Egyptians knew this years ago, and they knew to use this electricity from this guy here, this Nile catfish, and the zaps from the Nile catfish could, if you grabbed it, would help cure your, not cure, but temporarily treat your arthritis pain. So we use this electricity, and we'll get to that in a very, very selective manner that allows precise delivery of therapeutic electricity for solving brain problems. In particular, in this situation, Parkinson's disease, but we can do that for a lot of other things too, and I'm happy to discuss that later. Most of you know neurosurgeons as people that fix and protect sort of the spine, and we can do that with hardware and instrumentation. Most of you think of problems such as Parkinson's as something that would be mostly in the realm of a specialist like Dr. Farmer, but I'll show you that while your traditional notion of neurosurgery and dealing with the spine and the brain might be one thing, we really, in movement disorder, bring together a marvelous collaboration between neurology and neurosurgery. And this kind of functional, what's called functional neurosurgery, actually has its home in Philadelphia. It was actually at Temple almost over 70 years ago that there were the earliest practitioners of that, these two guys, Spiegel and Weisses, that were doing operations somewhat akin to what we're doing today. And so we really inherit a wonderful legacy of that here in this city, and we're happy to continue that. What we do surgically, and this might be a little bit cart before the horse because some of you might have questions of, well, why are we jumping to surgery? Well, we're jumping to surgery because I think that there is a wonderful opportunity for surgery to help folks with Parkinson's disease and movement disorders. The surgery that we do very specifically is called stereotaxis. It's a Greek word, and it's basically, think of it as a way of providing surgical expertise in such a precise way that it's like GPS. Some of you might remember the science fiction writer Arthur C. Clarke. He first proposed something like this, like a satellite system, years ago, and we have taken up that gauntlet or that mantle in systems that look like this. This is a little older of a system. It looks a little bit barbaric, and many of you would say, I'm not submitting myself to something like that, but we've done over time refinements, and we have a system that I think gets some of our oldest patients through, and even some of our youngest patients, folks as young as 10 years old, through surgeries quite successfully. What our system relies on, the one that we do at Global Neuroscience, it's a minimally invasive system, and we're all about trying to advance technology to be less invasive and more minimally invasive. We use these small little 7mm screws, and they actually go into somebody's skull. It's like a very dramatic piercing. But by doing that, we're able to have a very low profile of apparatus that's used for targeting, and our patients are then far more comfortable, and they're awake in operations, and they're engaging with us. And you can see it's not as daunting as you might think. It might be easier for me to say, but we've gotten so many people through this that I know that we can get anyone else through it as well. Neurosurgery is not unlike many aspects of our lives, and it's location, location, location. And what we're talking about today, Dr. Farmer has many of you versed on the fact that there are medications for Parkinson's, but there's also, as we're talking about now, surgery for Parkinson's. And the surgery is done in a manner that targets a very, very specific nucleus or collection of cells in the brain. And these cell spots are relatively small. They're only about 6mm, which is about 1/4 of an inch. And so it really takes somebody that's been doing this for a while, an expertise in order to do this successfully for you. And we have that expertise, and we've done that here at GNI, and I've done that for the last 20 years in my practice. So we're really well equipped to discuss with you various different targets in the brain that may or may not be of benefit to you in your disease process. I'm going to include a little video because I think videos usually say the full story. And you can see this patient, he's awake, he's in the operating room, and he's shaking. Okay, we appreciate that because I think it will help people. What we're going to do is periodically throughout the case do some other videotaping to make sure that we're able to document the success of your procedure. Okay, Dale? All right, we're going to get started now, Dale. Thank you. So you'll see here that there's a horrible shake. Our patient here is left-handed. That's why we're focusing on the left hand. Now we're in the brain. We're going to turn electricity on. Okay, we're going to go on now. 100 milliamp, ready and on. Okay, wow, Dale. Sweet. And you can see it's about the closest thing that comes to magic for us. Let's see. Where are you? And you can see something that he wouldn't have been able to do before, hold a cup to just take a drink, which would have been impossible. Now he's able to hold that. And then when we go off with the therapy, it goes back to his baseline state where he would make a mess if he tried to feed himself. You might feel something. And now we turn the therapy back on. Wow. All right, Bill. That looks like we're getting really darn close. Yeah, it's awesome. You can see how we haven't helped the right hand yet because he's still shaking there. But that's just one patient of several patients that we've been quite delighted and successful in. This is exactly the frame that we use, this sort of pre-customized frame, not a generic frame for just everybody, but with these screws, we can create this frame specific for your brain to very precisely localize that target in your brain that will help stop the symptoms of the movement disorder. We don't treat the disease in terms of curing it, we treat the symptoms, and I think for most of you, that's really what you're looking for. Some parts of what happened in surgery are very, very technical, and we are actually listening to your brain, and you'll hear this. Oh, sorry, let me see if I can go back. You'll hear that noise. That's a noise of brain cells telling us where we are in the brain. The brain, in a way, is like different regions, just like different countries of the world, and different countries have different languages. And as we get to different areas or different regions of the brain, there's a different electrical language. And when we get to the area that is part of the tremor, for instance, you'll almost hear this very rhythmic type of noise that lets us know that we're exactly where we want to be. And then we know with a high degree of certainty that we'll probably be able to afford a very, very wonderful outcome. This slide is just a montage of what happens in the operating room. It's a busy place. It's a busy space for this kind of surgery. There are a lot of people involved. It's not just me. It's anesthesiologists, it's technologists for the recording. We're very lucky at Global Neuroscience that we have our own neuroanesthesiologists. I have the same recording person that has been with me for the last 10 years. It's done all of my deep brain stimulation cases. So we're a really, really seasoned team in the sense that we know how to do this and do it quite expediently. In the end, when everything's done, when you get your electrodes, these are pictures of the brain. These are called CAT scans. And you can see these two little points. Those are the electrodes that are now in the brain. The electrodes in the brain are what deliver the current. And you can see over here, these are the electrodes going deep within the brain. There's wires that curl down and around the neck. And then ultimately they connect to these battery packs that look almost like they're akin to pacemakers. And that's really what happens from my part. Once that happens, then that's where the team building part takes place. And that's when I hand it back over to Dr. Farmer, who works on the programming. So some people call this functional neurosurgery. We also call it neurorestorative surgery. We use very strict ethical guidelines in terms of who we do operations on. We're always at the forefront of technology innovation, and we're always trying to do less. We're always trying to do more for our patients with less invasive procedures. And that's really one of the hallmarks that we have in functional neurosurgery and in global neuroscience as a rule. I'll just leave you with this slide. This is actually one of our patients in the OR, and I know that from everything that I've said, it might seem like this is all quite confounding and distressing, but I think the excitement for the patients to have therapeutic relief makes them very excited to move forward. So with that, I think I'm done, at least for my part of the presentation. I could go on for a long time with this because it's not a trivial sort of endeavor, but I think that both Dr. Farmer and I are here really to answer your questions because, well, that's what this is for. This is for your education and for your information. So Jill, I'll hand it back over to you. Jill, somehow I'm not hearing you.
Sorry, I was on mute. I was saying that was fascinating, and I love seeing the intraoperative pictures because it is, I mean, you say the term magic, and it really is something that is quite magical with a little bit of electricity, with a little bit of current, to see the symptom that we've been having difficulty treating with medication just sort of dampen away. And it's, the patients often ask me, and medical residents and students and everybody, well, neurology is such a tough field. Like, why do you want to do this? And I said, well, my part of it, our part of it, is not a diagnose and adios field. We actually have wonderful treatments, both surgical and medical and rehab strategies all together that can really maintain a good quality of life for our patients. So with that, we do have some questions that are rolling in, which is perfect. I'll start actually with a question that we got that was sent prior to the presentation, because it really is a wonderful jumping off question about who's the right candidate for someone with DBS. I'll leave names and everything out, so it's anonymous, but the information is not uncommon. So a patient diagnosed 12 years ago with right-sided tremor that has been managed on multiple medications, both carbidopa-levodopa, Gocovri, Artane, which had given him good control for some time. Takes medication very frequently throughout the day, up to 9 times. And there's other than the motor symptoms that he's experiencing, not really having much by way of non-motor. Some anxiety, some, of the usual cognitive features that we see with Parkinson's disease. Would this be the type of patient that should be considered for DBS? And just from that history, the answer is yes. So basically, oh no, go ahead. What were you going to say?
No, I was going to say absolutely. I mean, that is perfect. And just for your patients to know, I think you and I are very much on the same page. There used to be a point in time where, so deep brain stimulation, just for your audience to know, is something that's basically got FDA approval in 1997. So in the last 23 years, there have been globally, not just the United States, but globally, about 150,000 cases, which sounds like a lot, but that's not really a lot. That might be the number of hips that get replaced in the United States in a year. So the expertise for this kind of procedure are very limited. And folks like Dr. Farmer who do this know that over time, rather than seeing patients later in their disease course, we're trying to capture patients sooner so we can give them a better quality of life. So I think if you've been suffering for 12 years, I don't know, Jill, what would you say? This is probably about the time to do it.
Absolutely. So I was going to say this is a great case presentation, if you will, because it really highlights the key features of considering being an applicant for DBS. So at its simplest, you want to know that you have Parkinson's, that you don't have one of the Parkinson's mimics or things like that. And when you followed a clinical course like this patient has, where it's going along as expected, then you can feel very confident that this is not an atypical Parkinson's, but idiopathic or true Parkinson's disease. The patient is taking levodopa, and they're taking levodopa frequently. So the goal of DBS is to extend the on time, if you will, of your medicine. So when your levodopa is working and working well, we want to build upon that. And instead of having it be good and then wear off and then take your medicine and be good again, if we bring DBS on board, we're able to extend that window where the medicine is working and you're functioning better. There is not much by way of non-motor symptoms. So you've had Parkinson's for quite some time. There hasn't been a dementia that's emerged. There hasn't been significant gait or balance issues that's emerged. And these are things that make a patient a good candidate to be considered for DBS, because we do know that the surgery does not help with those particular Parkinson's features. So it helps with the motor symptoms, the tremor, the slowness, the stiffness, most importantly. If someone has a significant cognitive impairment, it may be a contraindication to considering the surgery. Not always an absolute, but it may be, because with the anesthesia, with the surgical procedure itself, there can be cognitive sequelae that come. And as far as balance, balance is a tricky beast in Parkinson's disease because it is managed by so many things in the brain, as well as external input and responses to stimuli in the environment. So the best way we can sort of see how DBS and balance would play with one another is to see if when your medicines are working and working well, can you tell that your balance is better and you're walking better? If you really can't tell that when the medicines are in your system, then it's something that we have to tease out a bit more to see what the impact of DBS might have on this. But for someone who is on medication, responds to medication, has had Parkinson's disease for at least 3 to 5 years that we know is following the clinical course that we expect, and they're starting to, what we say, narrow that therapeutic window where they're taking their medicines more frequently, or they're having a little bit more motor fluctuations where it works well sometimes and doesn't work as well the next. That is when the conversation for DBS should absolutely be considered. And for patients of mine that are participating in this webinar today, you know that when I'm speaking to you about all your options that are available, I place the surgical options like DBS right there with the medication ones, so that you know that it is a spectrum of treatment that is being thought of to get you to your best quality of life. So thank you for asking this question, because it really helped us get to the meat and potatoes, if you will, of what we should consider when someone's considering DBS. For tremor, I really can't think of a better option for therapy when your tremor is not responding to the medications at all, or when your tremor is not responding as well as it used to. So let's see, we have another question
also,
that came.
Jill, I would point out
Mhm.
that, there are some people that don't tolerate the medicine that well.
Good point. Yes.
So if people are having intolerances to the carbidopa, levodopa, or if they're having some kind of dyskinesias and things like that when they're in their on state, that's also something to consider. So absolutely. But let's go on with more questions. This is great.
Yep. So the next question is there a standard process for DBS startup and fine tuning? Is there an established process that you would use to decrease the amount of medication you were taking? Is there a standard or normal range of settings you would use with a new patient? So the answer to all three of those questions is yes, but it's a little bit of a caveat. So for the startup and fine tuning, I would say I'll let you speak to what happens immediately post-op after the leads are placed. So,
sure.
And I'll take it after that.
Yeah. So I think that there's indeed, yes, this is a very highly regimented procedure, but then we're all individuals. And a lot of what happens in the operating room, there are different, if you look online, you'll see different places do different things. Some places will do these operations with their patients asleep, which might sound much more comforting to the patient, but actually in the operating room is the only time we have the option to make a change. So we're going to take that time to make sure you're optimized in the operating room before I send you back to Dr. Farmer. So I think it's that little bit of extra work that I do in the OR that we can then convey. Again, we're a team and we practice within a continuum where we say, hey, these are some settings that really work in the OR, and that gives Dr. Farmer a really, really nice sort of set of parameters to know where to start. Generally, and programs are different, but typically we wait for about 4 weeks from after the implant for Dr. Farmer to start her programming. And then the feedback that I usually get from the neurology side and from Jill is that it takes anywhere from 2 to 3 months to really sort of get into a groove. And then pretty much your programming doesn't change for quite some time.
And so that's the first step. And then once the DBS is placed and the pulse generator battery is placed, I see you in the office, as Dr. Sarkar said, in about 4 weeks or so post-operatively to start programming. And at that time, that's a relatively, not a long visit, but it's longer than your usual visits that you would have at the neurologist, because I check to make sure that everything in the system is working properly. So we do a review of each little contact. If you remember on one of the slides that Dr. Sarkar showed, the lead that was going in had 4 black spots on it. Those black squares are actually where the stimulation is occurring, and we need to make sure that at each of those black squares, everything is flowing properly and everything is working well. So I do a review of all of those contact points. And then part of that review is to see which one controls your symptoms best. So if we're at the most bottom one, the middle one, the slightly higher one, or the one on top. And all this time I'm taking notes. And as we're at each contact point, there are 3 variables I can change through programming. There's the type of stimulation, so the potency of it, the amount of voltage or current that's going through. There's the pulse width, which is the, shaping the curve of that stimulation. And then there's the frequency. How fast is that stimulation actually working to exert an influence? And those 3 variables are what I adjust in order to give you symptomatic control. Now, we don't adjust all 3 variables every single time, all the time, because there are millions of combinations. So to get to the next part of the question, is there a standard that we use? To start off with, yes. Typically, the range of 130 hertz to 185 hertz for frequency is where we kind of start for tremor. Pulse width, we usually start anywhere between 60 to 90 milliseconds. And then voltage, we would ramp that up slowly, the same way you would ramp up medication slowly. So you're not starting with 9 tabs of Cinemed a day, so you're not going to start at 5 volts. We might start with 3 tabs of Cinemed a day, so you might start at 1 to 2 volts, just to kind of get things going to see how it works. The other thing that we look for when we're doing these tests and settings is to see how well you tolerate things, because just like medication, there can be side effects. So if we go too high, does it cause you to feel like you have a tingling feeling, or do you feel as if your speech might be affected, or do you feel as if you are having any tightness or pulling or things like that? These are not things that always persist. They are very much dose dependent, if you will, of the amount of stimulation that you have, and they change with time because your brain changes with time. So you might not have been able to tolerate a very high voltage to begin with. You might not have needed one that high, which is why. Same way you did not necessarily need to tolerate, 9 tablets of Cinemet to begin with, but when you started, 3 tablets were all you needed. And so you gradually worked your way up to it. So that then gets to the part about medication. Typically speaking, the different targets that we spoke about have different impacts on your effectiveness to be able to reduce medication. And the one target, which is probably the more common target that we pick, is the subthalamic nucleus. And that one in studies has been shown to reduce the amount of medication by about 40 to 60%. But you don't start off with that. There is no particular protocol of how to reduce the medicine other than to do it slowly. So if someone's on multiple tabs of Cinemet a day, and we're doing the DBS for tremor, and we know that the Cinemet wasn't really getting to their tremor control completely, if they're taking 2 or 2.5 tablets of Cinemet with each dose, then we might start to reduce by a half tablet each week to slowly bring you down to about half that while increasing the DBS going forward. If you were if you had medicine on board that was causing you side effects, which is one of the reasons why you were considering DBS, then obviously that's the medicine we would look to reduce first. So while there are plans of how to approach all of these, it does become very individualized for each patient. And while I just spoke about something that sounds incredibly complex, it is not. When you're face to face with me in the office and as we're talking through it, it's a marathon, not a race. So we take it slow, and I'm not looking to do anything overly aggressive with programming or to make wild medication changes. We're going to walk you through this process gingerly with very frequent visits. Sometimes my initial DBS programming is done every 4 weeks, just so that we stay on top of things and are able to kind of keep you moving in the right momentum. But then after a few months, once we sort of hit that sweet spot, if you will, we're able to space it out the same way that we were able to space it out before. Usually my typical follow-ups are every 3 to 4 months or so. And that kind of is what takes over. So I hope that answered that question. So what else have we got?
I think another thing that it would be very important for your patients to understand is that DBS is not like a light switch. It's not an on or an off. I like to speak of it like a dimmer switch, where it incrementally can be adjusted, and depending upon how you're coming down with medication, we can come up with electricity. So now that currency of the brain, the electricity takes over more rather than having to deal with the medications.
I have another question. What if you have a minor tremor? Are you still a candidate for DBS? And the answer to that is possibly, because DBS is useful for the motor symptoms of Parkinson's disease. Not everybody does DBS for tremor. So if tremor is not your predominant symptom, but you still have a robust response to medication and you're taking medication frequently, the reason for doing DBS might be to keep your symptoms where they are, reduce the amount of meds that you're taking, and then sort of reset the clock on that, because you will eventually have to bring meds back. It will take years, but you will have to, because the disease does progress under the DBS. So while the tremor, the stiffness, and the slowness are being addressed by both DBS and medications, there are other aspects of Parkinson's that might need to be addressed with medications that the DBS does not, which is the reason why, as time goes on after the DBS is placed, eventually you might have to bring more medications back on board. So if you're not looking for DBS to treat the tremor, but you're looking for it to reduce medicine, that's a valid discussion and something to consider. If you are, I'm sorry, my kids just walked in the background. If you are thinking of doing it for a not just medication reduction, but also because you have slowness or stiffness or kind of a dystonic posturing with your medications, that's another reason to consider DBS. So like I said, it's the 3 motor symptoms that we use it for. What has the most dramatic response is often the tremor, as you saw in the video, because that's something that you can see and then not see. But the other aspects are helped as well. And another question is, what is recovery like from DBS? So I'll let you take that, Adam.
Yeah, sure. So one thing I would also say to the last question is, even if you have a slight tremor, it depends on what your, say, occupation is, or even what your hobby is. Maybe you're retired and you're a fly fisher person and you want to tie ties or flies, or I remember one of my patients had that. And so that slight tremor really was a nuisance for them, and it wasn't something that they could get fixed with medication. And so that was a reason to move forward. So everyone has individual needs. I think post-operatively, remarkably, it's a surgery that in a way, I do lots of different types of surgeries, from various brain surgeries to spine surgeries. And our DBS patients tend to do better. The caveat to that is that they tend to be a little bit older, so generally in their 60s or 70s, sometimes even in their 80s. So surgery is always a little bit more challenging to recover from as you get older, but our deep brain stimulation patients tend to be back to themselves by about 4 weeks for sure. As early as 2 weeks, but for some folks up to 4 weeks before they really feel like they have that same get up and go. But that's okay, because that also helps correlate at the time that when Dr. Farmer is going to see all of you folks in the office again.
Mm-hmm. One of the questions that hasn't come up, but it does come up, and since we're talking about recovery, is what about the head shaving?
Yeah, so that's a issue that is a real controversy in neurosurgery, whether hair promotes or is a deterrent towards a clean surgical field. In the past, we've always gone to full head shaves because we're putting devices into your brain, and if there's an infection in the device, there's an infection ultimately in the brain, which is a huge problem. If I'm not mistaken, we will very soon have on board a plastic surgeon that we're going to start creating a protocol where we can do more and more minimal sort of and optimize the cosmetics of the events around our operation. So right now, I would say you're going to end up with hair like mine, which is short or non-existent, but we are moving to a point where cosmetics will also have a high value, and I think that we'll be able to offer that.
A question about non-motor symptoms. Does DBS help with anxiety? Can it improve sexual function or libido? Can it improve that uncomfortable feeling that you have when you're off? So non-motor symptoms are more tricky, and the FDA answer is the DBS is meant to help and improve motor symptoms of Parkinson's disease. But we know that motor and non-motor symptoms are impacted by your medications and how you respond to dopaminergic meds. And then we also know that DBS is meant to extend that benefit of those dopaminergic medications. So the answer to that is, if these symptoms are improved when the meds are in your system, then it may have an impact, a positive impact on those non-motor symptoms, but it is definitely not something that we would ever say, get DBS to help with anxiety, get DBS to help with sexual dysfunction. It really only is in the context of how well those symptoms already respond to the medications that you're taking. That uncomfortable feeling, that akathisia, as we call it, that absolutely can be helped. Because again, that is an on-off phenomena that is clear. And we know that if we were able to extend that on period with the DBS, then that feeling is something that can be improved. DBS outside of Parkinson's is used for other things, and it is used in the psychiatric world for things like OCD and other refractory psychiatric conditions, Tourette's, stuff like that. But it it's not something, the targets are different, and it's not something that we would say is indicated in management of Parkinson's symptoms at the moment.
But I would also say, Jill, with regard to anxiety, I know that many of the patients that I've seen over the years, their motor symptoms actually play into their anxiety. And
absolutely,
if they can get those, like, everyone thinks about the tremor, but the slowness and the rigidity are things that make many of our patients feel apprehensive about moving or falling or feeling like they're stuck. And I think that if we can ameliorate or relieve some of those pressures on them, I've seen people actually blossom because they feel we're not taking care of everything, but we're creating a positive impact on one of the spheres of their lives, which helps and goes a long way.
Absolutely. And my patients, again, that are on this webinar will know that they've heard me say multiple times, you cannot disentangle mood and motor symptoms.
Yeah.
The pathways in the brain are literally intertwined. And so if your motor symptoms are feeding into the mood, then absolutely. If the motor symptoms can be controlled, then the mood improves. What are activities that you cannot do once you have the surgery? I don't think there are much, Adam. Is there anything that's particularly off limits?
No, absolutely not. Maybe for the first 6 weeks while your incisions are healing, if you're somebody that likes to be in the pool or in the water, or I'm being facetious, but not really, in a sauna, we don't want these areas to be sweating or wet. But after that, then, going back to the barber, getting your hair colored, which is a question that I have asked, or doing any other activities, there is no restriction.
Yep, I would agree. I've had patients that were motorcyclists that go back to being on motorcycles, horseback riders back to being on horseback riding, rolling the roller coasters and all that kind of stuff. If we're doing things that are even more adventurous than that, then more power to you. I don't want to stop anybody from doing anything. So, but yeah, there isn't anything that's particularly off limits post-operatively in the long term. And let's see. There are now multiple companies that are doing DBS devices, Medtronic, Boston Scientific, St. Jude, Abbott. So we had a question is, which DBS system do you use? And is there, a particular reason as to why, what is the choice is?
So I think that that's a very reasonable question, and I have to say it's a tribute to, and Jill, you know this, to the Parkinson's and the movement disorder population. They seem to be some of the most well-informed. Again, I do surgeries on a variety of things, but it's the deep brain stimulation patients that usually come to me with a list of questions because they are just the most informed about it. So the fact that they know that there are multiple different companies is also a tribute to their sort of their pre-homework. There are 3 different companies. The biggest one is called Medtronic, and I'm not trying to promote them or dispromote them, but they're just the ones that have developed this technology. But that, just like with cars and you have Henry Ford, it doesn't mean that there aren't other kind of cars out there, some that may be more magnificent than Ford, but doesn't mean that a Ford doesn't work. I think the benefit of Medtronic, not to be an advocate, is just that they have this incredible length of time of over 20 years in developing this product. There are other companies that have nuances to the way the electrode can deliver electricity. There are slight nuances to all these other things. But what I would say is let me and Dr. Farmer take care of that. There's even great advances in technology in the battery, where the battery is getting smaller, and not only is the battery smaller, it can record local brain field signals and use that as a way of helping us tailor your therapy. So we'll worry about that, not to be patronizing, but I think that you're right, there are multiple groups, and we work with the groups that work best with us.
I agree with that. I've been trained and have done the majority of my programming through Medtronic as well, simply because they were the company that was doing it. Because I am a movement disorder specialist and I pride myself on being up to date in all of the things that are available, both medication-wise and device-wise. I'm also trained on how to program and use the other devices as well. They just haven't been implanted as much, so the experience with them, simply because they're newer, is less. But I would say that it usually becomes a neurology neurosurgeon decision as to which device to use, because overall the symptom improvement that they deliver is fairly consistent across the board. We got some other questions, and this is an interesting one. This one hasn't come up before. How does deep brain stimulation differ from the shock treatment that had been used in mental clinics in years past?
Yeah, so I think this goes back to me saying that, and Dr. Farmer may have even alluded to this. So DBS, believe it or not, is being used in things like refractory depression, suicidality, and those are some things that have had ECT, electroshock therapy. If you think about it, ECT is a big bludgeon of a hammer that puts two electrodes on each side of the brain, and it literally zaps the brain. It causes some transient amnesia, and it's probably it was important, but it, as a therapy to get us there, but it really is not nuanced. And so these days we're doing things like OCD, I think Dr. Farmer mentioned. We have a patient right now that we're evaluating for Tourette's syndrome. And these kind of therapies with local delivery of electricity to a very prescribed region means that we eliminate side effects. There's no point in giving a bludgeoning amount of electricity to the whole brain when you only have to stimulate a few millimeters of tissue. And so I think that that's the real beauty and elegance of DBS. And that's why I think both Dr. Farmer and I are so excited about using this, not only for movement disorder, but expanding it to other brain pathologies, including things like epilepsy, which I know this group is not necessarily their focus, or other neuropsychiatric issues.
So we're coming close to the end, and we just have a few more questions. I had mentioned that speech is something that can be impacted by DBS. Is this something that can be fixed with a DBS adjustment? The answer is possibly. So remember when I was saying there are those 4 black squares, which is the areas that exert what we would call the sphere of influence, if you will, the region that's getting the most electrical activity around the brain. We try to pinpoint it and target it, just like Dr. Sarkar said, but it is, the brain's not very big. So you are eventually going to hit other areas that do other things that may exert a possible side effect. So we try and shape that sphere as best we can, or move it around on that lead to potentially avoid side effects. And we're pretty good at it. There's a lot, remember I said there's a million combinations. There's a lot of ways to manage symptoms positively and improve side effects just by manipulating how the electricity is delivered and the shape of it and where it's located. But it's not always. And speech is something that is a problem with Parkinson's to begin with. So whether this is something that's related to a side effect of DBS, you would know it if we moved it around and the speech improved. It would be fairly obvious, the same way that tremor can kind of dampen fairly quickly. If it didn't, then it might be more Parkinson's related. And again, can't not stress the importance of therapies. So that's where we go back to the loud therapy, and same thing for balance, because is balance worsened by DBS, or is it just part of the Parkinson's symptoms that you have? Again, if we reduce some of the effects of the stimulation, if the balance improves, then possibly it was related to the DBS. If it doesn't, then it may just be more a Parkinsonian symptom, and we go back to the physical therapies or the occupational therapies, the BIG, the Parkinson's Wellness Recovery, the Rock Steady Boxing, all of the things that you don't stop doing just because you got DBS. So there was another question that came through and asked if DBS is a one-time fix. And it's not. It's again
Jill,
on that spectrum.
I would say
yeah.
one thing that this is, I think, a real benefit that we have in our group. So Bob Saddleoff is one of the premier ENTs in Philadelphia and even nationally for voice. And you know, he and I are co-directors of what's called the Philadelphia Voice Tremor Center. And so we're very fortunate not only to have you know, neurosurgery and neurology as close colleagues, but also to have ENT, an ear, nose, and throat physician, surgeon, as a close colleague. So we can always get our patients to Dr. Saddleoff, and we may even start having him see all of our patients up front, because as you point out, hypophonation or low voice or things like that, while we hear it and see it and have dealt with it, they're really specialists, and they're part of this whole package of our functional neurosurgery program.
Excellent. And the other question that we got is just something I'll reiterate is somebody asked if they don't have a tremor, are they a candidate? And again, DBS, while it focuses on the motor symptoms of Parkinson's disease, tremor is not the only motor symptom of Parkinson's disease. So while that's the symptom that everybody thinks about, it can help with slowness, it can help with stiffness. And again, if you are taking higher amounts of medicine and you're slowly ramping up that amount, and we know that's going to be the trajectory because that's what happens as the disease progresses, then considering DBS to sort of plateau where you are with medication, maybe reduce it a little bit to reset the clock, and then consider adding more as it's needed going forward. So there are other reasons to consider DBS, not just because of tremor, even though that tends to be the one that people most commonly think of. And then the last question that we had was, and I don't know if you have this on any of your slides, do you have a slide showing the device installed?
Yeah, this is, let's see, did this come up on the screen now?
So yeah, that showed the batteries.
Yep, that's the battery, and then we've got, and then that, if I go to a bigger screen here, that shows, this is the lead. Dr. Farmer was alluding to the fact that there are 4 contacts here. It goes all the way up to the top of the skull, and then the wires kind of curl around, and this is literally an extension cord. Think of if you were vacuuming in your house and you needed to get to an extension cord, that's the extension cord. And this extension cord is a little bit more of a robust wire as opposed to this delicate wire that's in your brain. And this extension cord comes down your neck and then to the front of your chest. So that's exactly how the system looks when it's in place.
And it's entirely internal. So
that's right. Yeah. Oh, yeah. Excellent point. This is entirely internal, and it would take a really close eye to understand that that's what you have underneath.
And how long is the hospital stay?
So each hospital stay is just overnight. So it's pretty remarkable. The hospital stay for the brain surgery is overnight, and the hospital stay for the battery implant in some patients is overnight, but in some patients it's actually the same day they can go home. So it just all kind of depends, and it depends on the source, the source and the quality of resources that you have at home. If there are folks that can help take care of you, many of our patients would rather be home than in the hospital. And if you're on your own, then we'd rather watch you before we let you go home.
And the last question, which is the practical question, does insurance cover this? And the answer is yes.
Yes, exactly. I was going to say that. The answer is a resounding yes.
As with any surgical procedure, as Dr. Sarkar said, there are many moving parts, and part of that, the benefit verification and the insurance coverage and analysis and things like that, are things that are done as part of our team. So there are surgical schedulers and coordinators and whatnot that go back and forth with the insurance companies, showing proof of documentation, showing the need and the benefit for the surgery to get insurance approval. And since most patients that are doing this are in Medicare, it is covered by Medicare, and that hasn't really been an issue. It's sometimes easier to do this than it is to get some of the newer medications approved and utilized. The other part is one thing that we didn't mention, and we'll wrap up with that, is how does one go about getting evaluated for DBS? Just what are the logistics of it? If you are not seeing a movement disorder specialist, you should see a movement disorder specialist. If you're seeing me, then that is something that we can talk about at your next visit if we haven't discussed it already. The best predictor of who is going to do well with DBS is somebody that is appropriately chosen for DBS. So that's why movement disorder specialist evaluation is very important, because we know the nuances, because everybody can look good on paper, but if there is something just about your clinical presentation, or if there's anything that gives us pause, then we need to investigate it a little bit further. Lastly, the process is, once you've decided this is something that you want to pursue, having an evaluation with Dr. Sarkar, having imaging, MRIs is important, and then meeting another part of our team called the neuropsychologist, which will do a formal neuropsychological test, just because we know that cognitive concerns are part of Parkinson's, and that any surgery is something that can impact cognition. We want to make sure that where you are in your clinical course is where you're expected to be, that there isn't an emerging more sinister cognitive deficit through Parkinson's disease, dementia, or something like that. And like I said, those are not absolute contraindications, but it is something then that we have to talk a little bit more about. The process for handling all of these appointments and things like that, again, is something that's done on our end. Since we're all under the same umbrella, we have people that can help guide and direct so that you're able to stay on top of the appointments, because it's a little bit of, a multi-step process, and help you with the neuropsychological testing and help you with scheduling the MRI and things. So that is sort of the process as a whole. And if it is something that you are interested and want to think more about now that you've seen this webinar, I am happy to help navigate that for you, to introduce you via a consultation to Dr. Sarkar, as well as the other parts of the process going forward.
Yeah, I think that's great, Jill. I mean, I tell the patients that, think of GNI as your general contractor. We're going to do some renovating, and we'll take care of it, and it'll all be under that GNI house.
So I hope you found this informative. I was very excited to introduce Dr. Sarkar to all of you, because it's just been a thrill and an honor working with him. And you see me in the office often, but you don't necessarily see the other members of our team. And I will happily take any questions that you have that come up after the fact. Either reply to that email or bring them to your next office visit. And if you'd like to figure out how to set up an office visit with me, you can also reply to that email, and are able to, we'll help navigate that with you as well. And with that, I think we'll close the webinar, and it was wonderful having you here. You asked wonderful questions, and I hope you found it a good use of your time on a Saturday morning.
Yeah, and Jill,
have a great rest of your day.
I'll reiterate, thank you, everyone. Thanks for introducing me to your patients, and go take care of your kids now.
Yeah. Bye-bye, everybody.
All right.